I'll go ahead and introduce him. He is someone that when I first moved to Arkansas in 2009, and I was teaching at UMS at the medical school, and I was wanting to find someone who was involved in substance abuse treatment. And somebody said, "Well, you have to talk to Dr. Mancino." And since then, he has been somebody that truly, a lot of people will say, "You can contact me if you have any questions." Um, but they often don't, follow through. But I probably send him an email every other month or so with a question, either about a concept about addiction, substance use, or about a patient or policies. And so he is someone that if you have questions, he will respond. He is graduated from medical school in Northwest Ohio and did some training in neurosurgery and completed his training in psychiatry at UAMS. And he's board certified in psychiatry and neurology, as well as from the American Board of Preventive Medicine, specializing in addiction medicine. Professor at UAMS Psychiatric Research Institute, and currently the program director for their Center for Addiction Services and Treatment. He's previously been the medical director of the Recovery Centers of Arkansas, and now he's focused in his clinical practice on medications for opioid use disorder and really bringing evidence-based treatment to Arkansas, and as well as being a national expert. He is involved in other clinical trials, and he is the director of the UAMS ECHO program and Matriarch, and they have some fantastic resources. So we are very fortunate to be able to have Dr. Mancino and his team in Arkansas.
All right, thank you. Let me see if I can share my screen.
I just wanted to give a quick disclosure, Dr. Mancino, and remind everyone this is being recorded. And if you do stay on today's recording, you're giving us your permission to record this, and we will be posting it to the ABIN website. Thank you for joining. And with that, I'll turn it back over to Dr. Gibson and Dr. Mancino.
All right, great. So today we're going to talk about treating opioid use disorder in primary care. And hopefully make you all aware of some resources that are available to you that you may not be aware of. So we're going to talk about how bad the opioid problem is, and then why do we want to use medications for opioid use disorder? And that's the new term. The old term was MAT, or medication-assisted treatment, and now it's morphed into medications for opioid use disorder.
Dr. Mancino?
Yes.
We are seeing your whole desktop that shows us the presenter view with next slide, notes, and all that, which is fine if that's what you like.
No, but not sure how to fix it.
If you'd like to send the slides to me, I'm happy to advance them also. You're welcome to email them to me.
And I think if you go to presenter view or play from this slide and start, then it'll have just the main slide that you want shown.
Okay. Let's see what's going on.
And
yeah, I'm not sure.
The top of the podium, click yes. Yeah.
Yeah, I'm not sure how to fix that.
You might just click on the bottom, just slideshow, the little bottom right. That,
Oh,
Yeah, I think the problem is it's showing a different screen that I want it to show.
all this technology.
Yeah,
It doesn't seem like it's getting easier, even though.
Yes. We've all become tech
There you
experts.
go.
there
you
it is. Okay,
Perfect.
Looks
Thank you.
wonderful. Thank you.
good. Okay. And then how can we expand access to medications for opioid use disorder treatment? So there you see a picture of hydrocodone on the left and OxyContin on the right, kind of a couple of the drivers of the opioid epidemic, especially here in the state of Arkansas. So how common is this problem? So this is the 2021 National Survey on Drug Use and Health, where they call a bunch of people on the phone and ask them a bunch of questions about their substance use, as well as collecting a lot of other data. And you can see there about 1 in 5 people from the ages of 12 to 17 have used a prescription that wasn't intended for them to be used. Almost 40% of what I call emerging adults, people that are age 18 to 25, have used a prescription that wasn't intended for them in the past year. So very commonly occurring event. And then over half of young adults in that same population have a lifetime non-medical use, meaning they're using a medication that's not prescribed to them. Emergency department visits. This is something that was actually eliminated in 2011 and then brought back in 2021 because of the significance of the opioid epidemic. And this measures what are the reasons for people visiting the emergency department. And this is the Drug Abuse Warning Network, or DAWN. You can see there are almost 6 million drug-related emergency department visits, the majority of which were related to drug misuse. In other words, a prescription that was taken incorrectly or overprescribed, that sort of thing. And almost a quarter of those were related to opioids. So how many folks have used substances? This is, again, data from the National Survey on Drug Use and Health from 2021. In the past year, over 1 million Americans had used heroin at least once. And about 66,000 of those were that young adult population, age 18 to 25. That pales in comparison to the number of people that have used prescription opioids. Almost 10 million people, or 10 times as many, have used prescription analgesics during that last year. So quite a few. And the scary thing is almost 500,000 were adolescents or kids aged 12 to 17. So they're starting very young. Opioid use disorder is present in almost 6 million people over the age of 12. And that last line there is a staggering number. $1.5 trillion annual cost in 2020 US dollars. So a huge cost to society. That includes emergency department visits, hospitalizations, incarceration, lost work productivity, etc., related to the opioid epidemic. This graph represents the what's called the triple wave, and we're actually in the middle of the fourth wave at this point. You can see there sort of the first wave is that purple line, which is sort of a steady increase in overdose deaths starting back in 1999 to this day. This is related to sort of commonly prescribed opioids like hydrocodone and oxycodone or OxyContin. The yellow line, which takes off in about 2010, is related to overdose deaths from heroin. And then the current wave, which is continuing to rise, is related to synthetic opioids or fentanyl. The fourth wave, which we're in the midst of now, is actually the combination of methamphetamine and opioids together. And we're probably going to have a fifth wave very soon, and that one is the xylazine, which has been introduced into the drug supply and is present now in the state of Arkansas. The problem with that is it's difficult to test for. Most tests don't detect xylazine, and xylazine is also not reversed by Narcan. So a very concerning new drug that's been introduced into the drug supply is headed our way. So this is specifically Arkansas data, and I kind of want to draw your attention to that chart there at the bottom. You can see admissions for treatment for opioids in the state of Arkansas in 2006, only about 40 were related to heroin. 2019, a little over 10 years later, almost 10 times as many admissions for heroin. And then other opioids have doubled in that same time frame, admissions for other opioids that includes synthetic opioids like fentanyl, as well as other prescription opioids primarily. How big a problem and how much treatment is available? So you can see there, that's where the $6 million number came from in terms of people that have an opioid use disorder. The majority of them have opioid use disorder related to pain relievers or prescription opioids. About 1 million of them are related to heroin. And less than half of those people that needed treatment actually received any type of treatment. And that treatment includes detox, where you send someone away for 3 to 5 days to try and get them past their withdrawal. I think the most important point on this slide is the idea that detox really doesn't work very well in this population. The incidence of relapse after detox within 30 days is over 90% of relapse rate in just 30 days after a detox episode. So we're not talking about a year or 5 years like we would refer to if we were talking about remission for cancer. We're just talking about a month. And of course, as everyone knows, access to treatment is restricted just because there's not a lot of treatment available. Okay, why do we want to try to address the opioid epidemic and the problem with medication? We have several goals for using medication to try to treat people with opioid use disorder. One of the most significant of which is to prevent, decrease, and or eliminate withdrawal symptoms. Withdrawal is a big driver for relapse to using opioids. We want to prevent or reduce drug craving. Drug craving is the second most common reason for relapse to using opioids, right? We talked about detox and how limited it is. And detox, we can get people through their physical withdrawal. The problem is, even though they're no longer physically in withdrawal with runny nose, watery eyes, goosebumps, nausea, vomiting, abdominal cramping, insomnia, et cetera, et cetera, et cetera, they still obsessively think about the opioids and how good that would make them feel and how much they miss them. And so that's the problem, is their obsessive thinking about using opioids. And then obviously we want to prevent relapse to use of their drug of choice. And we'd like to get them to lead a life of sort of normalcy, right? Getting up, going to work, taking care of the kids, going to the grocery store, participating in church activities, whatever it is that they view as being normal for their life. They probably haven't engaged in those normal behaviors for some time. because the drug use disorder has taken over for them. The problem is this sort of approach has created a dichotomy in the way people think about medications for opioid use disorder, with one sort of approach being medicate first and ask questions later. And I often say, some people say, let's fill a candy dish with Suboxone and leave it on the front desk at the clinic and let people come and take as much as they want. Versus, sorry, no water, we're just a support group, which is the opposite end of the spectrum, where people sort of feel like, well, we shouldn't ever use medications. We're substituting one drug for another. That's just a crutch. So I've heard all these arguments on both sides. And my position is actually somewhere in the middle. I think medications are an important tool that we need to take advantage of. So what are medications for opioid use disorder? The most common one, the one that's been around the longest, is methadone. Unfortunately, methadone can only be dispensed through an opioid treatment program or a quote unquote methadone clinic, which we have one here at UAMS, but our business is not as good as it has been in the past. Shortly after Hurricane Katrina, we actually had over 160 patients in our methadone clinic that included people that were displaced because of the hurricane. And now we're down to about 50 patients in our methadone clinic. And then naltrexone, which is sort of the drug that's favored by the criminal justice system, because naltrexone is an opioid antagonist and it doesn't have any activity at the mu opioid receptor. And then finally, the drug that's sort of become more commonly used is buprenorphine. I'm not going to focus a lot of time or attention to sort of describing the ins and outs of buprenorphine. Most of you have probably heard this before. But I want to highlight one thing especially, and that is previously, in order for a prescriber to be able to prescribe buprenorphine containing products of any kind for the treatment of opioid use disorder, you had to have a special 8-hour training and get a waiver from the DEA. That requirement has been eliminated. And so any prescriber, physician assistant, APRN, MD, DO, can prescribe buprenorphine without needing to have a special waiver to allow them to do that. And the interesting and, in my opinion, exciting thing is that instead of requiring people that have the waiver to take the 8 hours of training online specifically about buprenorphine and substance use disorder treatment to a certain extent, the DEA is now requiring all prescribers who have a DEA to receive 8 hours of training around substance use disorders. And they basically have not prescribed any particular route of obtaining the 8 hours. So you can use any route of obtaining the 8 hours. You can attend an in-person session. This certainly would count as 1 hour towards that 8 hours. And then there are many online approaches that you can take. And one of the ones that I'm recommending for the entirety of UAMS is called the Provider Clinical Support System, which offers a variety of modules on substance use disorder. There's over 20 plus modules, and I've sort of identified 7 of which I think everyone should have, and then 1 that they can take on their own based on their specialty or potentially based on their interest. Interestingly, buprenorphine, most of us are familiar with the sublingual form of it, but now there are other approaches that are available, including transdermal patches, but those are prescribed primarily for pain. And the subdermal implant, unfortunately, has gone away. It's no longer available on the market. And part of the reason for that was it required a surgical procedure, and most psychiatrists don't want to mess with surgical procedures. And once you implant it, it's 6 months of treatment, but you can only implant it twice, once in the left forearm and once in the right forearm. And if this medication is designed to be a maintenance drug, that doesn't provide very much coverage. Also, it makes it difficult to engage the patient in counseling and therapy if they've got medication that lasts for 6 months. Plus, the dose had to be very low, and we have very few patients on as low a dose as was necessary to make the subdermal implant feasible. And then you see their sub-Q depot injections. There are now 2 drugs on the market. One is called Sublocade, which has been around and FDA approved since 2017. It has 2 doses, 100 milligrams and 300 milligrams, that can be given once every 4 weeks. And the beauty of these medications is it can really decrease the incidence of diversion. And then there's a new one that was just recently FDA approved, which is called Brixadi. That will hit the market sometime in September. And the nice thing about that one is they actually have weekly injections and monthly injections, and they have a wider dose range that's available. So what is the impact of medication for opioid use disorder? And I'm going to highlight specifically buprenorphine, since that's really kind of what we're talking about today. It decreases opioid use and improves treatment retention. It improves outcomes in prisoners, meaning it decreases recidivism to commission of criminal activities. And it also has improved outcomes in pregnancy, both for the mother as well as for the baby. Significant decrease in what's now called neonatal opioid withdrawal syndrome, or NOWS. And then more recently, we've got clear documentation that it decreases mortality. That's taken some time to demonstrate. That was one of the benefits of methadone that was superior to buprenorphine until recently. Was methadone clearly decreased mortality rates, but more recently buprenorphine's been demonstrated to decrease mortality as well. So buprenorphine, methadone, these are considered opioid agonist therapies. And you know, I have patients that have tried methadone and it just doesn't work for them. I've had patients try buprenorphine and it just doesn't work for them. I've had people try both of them and neither of them work for them. And they find that abstinence is actually more beneficial to them. However, opioid agonist therapy helps a tremendous number of people. It's just that it doesn't help absolutely everyone. And the other point that I often make when I'm giving these presentations is I believe medication is an important tool in the treatment of opioid use disorder, but I only view it as a small part of treatment. Whereas I view counseling, therapy, group sessions, case management, etc., as the most significant thing in terms of treatment. Part of the problem is that if all you do is give a patient medication, they've often missed out on how to function as an adult in society. And so unless we show them sort of the things that they should have been learning while they were starting to use drugs during their youth, you know, that 12 to 17 age group, which is commonly when people start using substances, they often don't know how to function in society. Yes, they may not be using drugs because you're giving them medication, but the problem is one of 2 things. The other thing is buprenorphine doesn't help with other substances, such as methamphetamine, benzodiazepines, stimulants, etc. And so they switch their drug of choice to a different drug that's not impacted by buprenorphine. Or they don't use substances, but they're miserable because they don't know how to live life. And either one of those, unfortunately, continues to cause problems for people's inability to function. So I've said that basically everyone can now prescribe buprenorphine as long as you have an active DEA. And so I want to talk about a couple of different programs that are available to support people that say, you know, I'd really like to do this. I have some patients in my practice that I think have an opioid use disorder, and I'd really like to be able to help them, but I'm just really not comfortable doing that. Well, these are a couple resources that are available. One is called Matriarch, and the other one is Project Echo. And we're going to talk a little bit more about each of those. So Matriarch stands for Medication Assisted Treatment Recovery Initiative for Arkansas Rural Communities. If you look at Central Arkansas, there are well over 75 doctors that were waivered before the waiver was eliminated. So there's a bunch of doctors that prescribe buprenorphine. So if you live in Central Arkansas, it's pretty easy to access medication for opioid use disorder, and specifically buprenorphine. But if you live in one of the four corners of the state, you're much less likely to be able to access it. Little less true in Northwest Arkansas, but certainly in the other three corners of the state, very few prescribers that are familiar and or comfortable with providing medications for opioid use disorder, and specifically buprenorphine. So the idea behind this was to offer a resource for some of the barriers that physicians said existed to prevent them from being willing to do this. So this is in partnership with the Arkansas Department of Health, Division of Behavioral Health Services, and the money to support this comes from SAMHSA. So this provides access to an addiction psychiatrist and other substance use disorder treatment clinicians to provide support to prescribers across the state of Arkansas that want to provide medications for opioid use disorder, but maybe just aren't quite comfortable with it to the point that they feel like they can do this independently. So this provides a resource, and we'll go into the details here. So this is a call center that's available Monday through Friday from 8:30 a.m. to 4:30 p.m. Those are the numbers there, the local Central Arkansas number, as well as an 800 number. And this provides for telemedicine consultation as well. But mostly people call and say, hey, I've got a patient with this side effect. What do I do about that? Or, hey, I've got a person with this problem. Not quite sure how to handle this. So it offers sort of pretty real-time. If you call us, typically the person that answers the phone will often be able to answer the question themselves. And if they can't, they can get with me, and then we can set up a time to call back and answer the question, typically within less than 24 hours. Sometimes the issue is around psychiatric problems. Hey, I'm not sure if this person is bipolar or not. They say they have a history of bipolar disorder, but I don't really know if they have bipolar disorder. And then what we have the prescriber do is fill out a form that gathers a lot of the information that I would gather in a comprehensive assessment, a psychiatric evaluation. And then I review that, and then we set up a time where we can actually do a telemedicine visit with the patient, which is fairly brief because most of the information has already been gathered. And then I assess the patient, and then I make recommendations for treatment of the patient. So I did one not too long ago on a lady that had bipolar disorder, and turned out she had been hospitalized a couple times here at UAMS. So I was able to go into our medical record and determine, yeah, this lady does in fact have bipolar disorder, and it's documented in our records during her hospitalization here. And she was on medication that was prescribed by the folks here, but somehow her primary care physician, stopped the medication for an unknown reason. And then she switched her primary care physician to another physician because her physician retired or something like that. And so we were able to make a recommendation that they restart a mood stabilizer in this person. And the important thing to understand is I don't take over the care of the patient. This patient is still your patient. It's just that you have a consultation from a psychiatrist that is an addiction psychiatrist. So the important thing to understand is this is available if you are providing medications for opioid use disorder. This is not a service that's available to say, you know, I've got this patient, I think they have bipolar disorder. I can't seem to get them into a psychiatrist. I'm just going to use that matriarch program and get them psychiatric care through that. No, this has to be a patient that you are providing medications for opioid use disorder to. So that information will be available. This is being recorded, so you can access those numbers and such. And I'm sure that those can be forwarded to you if anyone didn't have an opportunity to write those down. The second thing that I want to talk about is something that is really interesting. This is known as Project Echo. And the idea behind Project Echo is moving knowledge instead of patients and providers. So as opposed to that method of telemedicine where I meet individually with one patient, this allows me to educate a bunch of different providers on various aspects of treating patients with medications for opioid use disorder. This is an event that occurs every Friday at noon, and it offers free CME or CE to every level of provider: pharmacists, counselors, physicians, APRNs, PAs, anyone that has a requirement for CME or CE is able to participate and get 1 hour of CME for free every Friday, typically at noon. Echo is a pretty an organization that started in New Mexico, and I'll tell you the story behind how it got started here in a minute. But basically, Echo is very eager to impact healthcare in a very positive way. So they want to democratize medical knowledge and get best practice care to underserved people all over the world. So this is not just something that's occurring here in the United States. There are Project Echoes that are occurring everywhere: South Africa, South America, everywhere. And you see there, their goal by 2025 is to touch the lives of 1 billion people, and they are very much headed that way. The goal is to develop the capacity to safely and effectively treat opioid use disorder in all areas of Arkansas. What are the benefits to rural clinicians? Again, as I've mentioned, no cost CMEs or nursing CEUs. It allows for professional interaction with colleagues with similar interests. So let's say you're the only doc in a county in rural Arkansas, and you're like, I'm doing this MOUD thing, but I don't really know if I'm doing it right. I'm not sure that I'm comfortable doing this. This allows you to get feedback from colleagues that are maybe in a similar situation who say, yeah, you're doing great. That's exactly how I would have done it. And in fact, I've had a patient with a very similar experience that I treated just like you're treating. And so it sort of reinforces what you're doing. It's a mix of work and learning, and it allows consultation with all of those specialists that you see there. Most of the time we have someone from each of those fields represented on the panel here in Little Rock. So going back to how did this get started? So in New Mexico, Dr. Sanjeev Arora was a gastrointestinal specialist who specialized in the treatment of hepatitis C. And when he started Project Echo, he was the only physician in the entire state of New Mexico that was treating hepatitis C. And yet there were, I think, 70,000 people or something crazy like that in New Mexico that had hepatitis C. And so if you wanted to get an appointment with him, it took 8 months to get an appointment to see him. And by then, a lot of people had significant damage to their liver. And so he said, how can I help prescribers throughout the state of New Mexico to be comfortable treating hepatitis C? It's not really, it seems really complicated, and the medication, especially at the time, was interferon, had a lot of side effects. It was effective, but it had a lot of interactions with other drugs and a lot of side effects, and physicians just weren't comfortable using it. Now it's a lot easier. There are a lot more medications that are very well tolerated with minimal side effects. But at the time, he created this Project Echo and got a lot of prescribers across the state of New Mexico to start treating hepatitis C. And the wait time to get in to see him decreased from 8 months to 2 weeks, because most of the straightforward cases were now being managed by physicians across the state of New Mexico. So the next logical disease state that they looked at was opioid use disorder had the same sort of problem. There were lots of people with opioid use disorder across the state of Arkansas. Most of the physicians at the time, physicians that were comfortable treating opioid use disorder were in New Mexico, which is in the center of the state, just like Little Rock is in the center of the state. And so they tracked how many people were certified to treat opioid use disorder with buprenorphine. And the gray line there is actually the projected trajectory with a slow, steady increase in waivered providers. And when they instituted teleecho clinic, they saw a much more significant increase represented there by the black line. So a whole lot more physicians were comfortable providing this care because they had the support of Project Echo and they didn't feel like they were doing this on an island. So huge impact on the number of physicians that were willing to get waivered and prescribe buprenorphine. So the idea is Echo is not traditional telemedicine, right? It's not me providing care to one patient. It is our expert central hub educating a bunch of other teams of providers across the state so that they can impact a whole lot more patients than if we were to try to take care of patients one-to-one. So it's really a significant force multiplier. And the treating physician retains the responsibility for managing the patient. So this is kind of what Project Echo looks like. You see the fellow there under the E in Project Echo. That's Dr. Aurora, and that's the central hub with all the people that are experts on treatment of hepatitis C. And then around the edges, you see the sites across the state of New Mexico. So that's actually how our setup is here in Little Rock. Is we have a very similar setup. And it's really interesting because now with the pandemic, the idea of Zoom meetings and that sort of thing has become much more familiar to people. And this sort of was Zoom on steroids before people became sort of more familiar with Zoom. It's really interesting, but Project Echo has a lifetime free license with Zoom, unlimited license with Zoom. And part of that is because Project Echo partnered with Zoom from the very beginning. And so Zoom actually built a lot of their platform for Project Echo. And so they have this very symbiotic relationship that has benefited both of the partners. And then this is the back of Dr. Aurora's head. That's that same picture taken from the back. And this is what Dr. Aurora sees. He sees the people at the sites across New Mexico up on the screen. And then the presentation is on another screen. And so you can see both things at the same time. And we have, again, we have this exact same setup here at UAMS. So how well has this model worked here in the state of Arkansas for the treatment of opioid use disorder? So these are numbers that we've collected from May of 2018 to September of 2022. We've had 171 medication for opioid use disorder teleecho clinics. We have been able to have patients in at least 61 counties receive medications for opioid use disorder as a direct result of providers that we've supported through Project Echo. And we've given out a total of 3,586 hours of CME or CE at no cost related to medications for opioid use disorder. So very significantly impactful project. What makes Echo work? You can see there all the things that kind of go through it, some of which I've already highlighted. I don't know if there's anyone on the call who has participated in a Project Echo. If you have, and you'd be willing to speak about your experience, that would be great, but I'm not sure if we have anyone that has actually participated in Project Echo as a provider. The purpose of this slide is to just demonstrate, I talked about hepatitis C and medications for opioid use disorder, but actually it's really interesting. These are all the disease states that have been sort of managed and education provided through a variety of Echo teleclinics. And you can see there a lot of the disease states are typically complex chronic disease states that are often very difficult to manage and are very complicated. So you can see there a significant number of disease states and health policy issues even that are sort of discussed utilizing the Project Echo model. Okay. At the very end here, I want to put a couple of slides in as an advertisement. We are about to have another request for proposal sent out probably sometime in August. We are always looking for partners across the state of Arkansas who are willing to provide medications for opioid use disorder, specifically injectable naltrexone and buprenorphine. And so if you become a partner with us, if you're willing to provide medications for opioid use disorder, then you can apply for funding to help treat everyone that comes to your clinic. Obviously, if they have insurance, you'll bill their insurance. If they have Medicaid, you'll bill Medicaid. But if they are uninsured or underinsured, you will be able to access grant funding to provide assistance to the patient for the prescriber evaluation, for follow-up appointments, for counseling visits, to cover the cost of the medications, to cover basic labs that are necessary, to cover transportation for the patient. If you go between two clinics, we'll cover your costs. Let's say your home base is in Russellville and you go to a clinic in El Dorado, we will cover the cost of transportation for the prescriber to drive between the Russellville clinic and the El Dorado clinic and back. So really provides the opportunity to provide care to anyone that walks through your front door without having to turn people away. And I'm going to let you kind of read through those. These are the eligibility criteria, and there are some hoops that you have to jump through to be able to get this access to these funds. And one of them is that we want people to do a presentation for Project Echo once a quarter to talk about a patient that maybe you're providing care for that you want to have some questions answered, or you can talk about a patient that you think is doing well and doing great, and you just kind of want to get some confirmation, or talk about a success story that you've had. All of those things are valid case presentations, and that's kind of what we do most times in Project Echo at this point. Some continued requirements there. And when the announcement goes out, all this information is included in the RFP or request for proposal. So if you think, boy, I think our organization might be interested in accessing some of these funds, you can just send an email to A Douglas, the number 2, A Douglas 2 at uams.edu, and she will get you added to the distribution list for potentially accessing these funds. All right, so that's my presentation for today, and it looks like we have some time for questions. So if anybody has any questions, I'd be happy to entertain them at this point.
Dr. Mancino, it's Helen. Hi.
Helen?
I have a question. What happens when someone who is going through MOUD all of a sudden stops treatment?
So typically they go through withdrawal, and typically they relapse to using opioids, and unfortunately they're at significantly higher risk to overdose because their tolerance has been reset. So that's one of the reasons that we don't really encourage people to frequently get off of medications for opioid use disorder.
I know that you have a grant that allows people who don't have insurance coverage to get MOUD coverage, but with the Medicaid unwinding, do you find that people under MOUD treatment all of a sudden have to stop because of that?
Yeah, what you're talking about is the idea that during the pandemic, patients' Medicaid was automatically renewed every year without having to renew it themselves every year like they had to prior to the pandemic.
Right.
And so a lot of patients get letters, or they've moved multiple times and Medicaid doesn't have an accurate location for them. So they may have sent them a letter, but they didn't get it because they've moved 3 times since they had to register for Medicaid previously. And so they either ignore the letter or they don't get the letter, and then they're unaware that their Medicaid goes away because they didn't renew it. And so, yeah, that can cause problems in terms of people continuing care. Certainly, if you have people that are in care that need access to treatment, we have a network of providers that we can connect people to that can provide this sort of treatment for people that maybe had their Medicaid run out while they get their Medicaid renewed.
Okay. I have 2 more questions, but I'll let everyone else ask questions because I don't want to take up your time.
Do we have other questions?
I'm looking at the chat. Whitney Gates, not as a provider, but my providers at CC have presented a few times. Great program and good ongoing CEUs for the providers. Arisa Health has participated and found it very helpful to have Peggy and me with consultation as we started our program. There's Anna Douglas's email on there if you want to get added to the list, either for Project Echo or for the RFP. Is there a resource list of providers that provide MOUD? And the unfortunate answer to that is no, there is not. There used to be a SAMHSA website that listed buprenorphine waivered providers, and that was outdated, probably 10 years ago. They never did anything to update that list. So I signed up on that list probably 18 years ago, and they never contacted me again. And during that time, I moved from the VA to UAMS. And so I'm still listed as a provider at the VA, despite the fact that I haven't been at the VA for like 15 years or something like that. So that list, unfortunately, was very unreliable and not well maintained. If you say have a patient that runs into that difficulty with losing their Medicaid and not having access to treatment, you can email Ann or Douglas, Douglas, the number 2 at uams.edu. And then if you tell us where they live, we can provide them the contact information for one of our grant recipients across the state of Arkansas to see if we can't continue their treatment.
Dr. Mancino, you also mentioned xylazine, and you said that it is in Arkansas. Can you tell us a little bit about how that's turning up in Arkansas and a little bit more about where we are with that in the state?
So xylazine is sort of a benzodiazepine type derivative drug, kind of has that same effect as benzodiazepine, but it's really an animal tranquilizer for large animals. And the way it's showing up is the crime lab has discovered it in several drugs that have been seized, like fentanyl, methamphetamine, etc. So when they've seized drugs during arrests and such, and they analyze the drugs, they've seen the xylazine in the other drugs. That's typically how it's being distributed, is in the context of other drugs, kind of the same way that fentanyl is turning up in other drugs as well. So fentanyl can be found in methamphetamine, and now if you have a methamphetamine seizure, you might find fentanyl and xylazine in it. It's probably not as commonly available in Arkansas as fentanyl is at this point, but demand will drive supply, and if the demand is there, the supply will follow, and that will increase with time. And the problem is there are a couple companies that do drug screens for it, but it costs a bit of money to do the drug screen for it. And so oftentimes most clinics don't actually test for xylazine, but that's one of the things that if you have an overdose situation and you give somebody Narcan and they don't respond to Narcan within the 2 minutes, and then you repeat the Narcan after 2 minutes and they still don't respond, you really need to be thinking, hey, maybe this is another substance. Maybe it's not just opioids. Maybe it's xylazine. Maybe it's, something else. So it's really important to consider that if the person doesn't reverse with Narcan with a couple doses after about 4 minutes, you may have to provide other care. You may have to actually intubate them and put them on a ventilator and provide supportive care to them while the substance is metabolized in their body, because I'm not aware of a reversal agent for xylazine. There is a reversal agent for benzodiazepine. So if you're thinking the person has benzos and opioids and you reverse the opioids, you can actually reverse the benzodiazepine too.
Do you think that the availability of over-the-counter Narcan in July, I think that's when it's coming, would have any impact here in Arkansas?
To be honest, no. I write a script for Narcan for everybody that I treat for opioid use disorder, whether they want it or not. You can walk into a pharmacy at this point and get Narcan without a prescription if you want it. The problem is if it's over the counter, oftentimes that means insurance isn't going to pay for it. It might be cost prohibitive. The company that's distributing it, I don't think is going to sell it cheaply. I think they're going to try to make a profit off of it. And so I'm not sure that it'll increase things. I think there is something for you know, the person that doesn't want people to know that they have an opioid use disorder and they want Narcan, but they don't really want to walk into their local pharmacy because they live in a small town and they don't necessarily want the pharmacist and everyone to know that they're getting Narcan, so they may try to buy it over the counter. I don't know. I just don't think it's going to make that big of a difference. And there are lots of Narcan available for free with many different programs in the state of Arkansas. So access to Narcan, I don't think is a huge problem. It's actually people being willing to use the Narcan. It's people being willing to have the Narcan used on them. I think those are the big problems.
Yeah. Thank you so much, Dr. Mancino. Helen, I know it's 9:01. There was a question, where can just the everyday person get Narcan? And just wanted to promote, I know that the Arkansas Department of Health, we have partnered with them and we've done some different trainings in some rural areas. They're providing free Narcan. We know that the Arkansas opioid AORP, I never get their acronym correctly, but they have received opioid dollars and they are doing a big push to get Narcan trainings out into the rural counties. This is advertised, social media. There's huge pushes to try to get Narcan in the hands of everyone that wants it. That's going to be a big push. Also wanted to just say, I know our HRSA project officers have been talking to us a lot about xylazine moving from the east to the Mid-South, and really one of the things they've said is for us to look out for necrotic wounds. When people are presenting with necrotic wounds, that could be a sign of xylazine. I don't know if you've seen that, Dr. Mancino, or.
Yes, I've seen that.
Okay. Awesome. Yeah, scary stuff. So thank you all for your time today. And if you're interested in Narcan personally, please reach out and we could try to connect you potentially with a Narcan training that's happening in your community. And we appreciate you so much for being on with us today and sharing all of this knowledge. Really, it's critical for us to know that there are lots of services in our populated areas, Central Arkansas, Northwest Arkansas, but really to get to our rural communities, it's critical for providers to be able to have access to resources like Matriarch. And so we thank you for making that available. Thank you all for your time this morning, and reach out if you have questions. And we are going to be taking a break in July, but we will be back with a webinar in August, and we will see you then. Enjoy the summer. Take care.